Hello, everyone. Thank you to the Avatar Foundation. Thank you to Dr. Jasuja and the organizers for inviting me again this year to give a presentation on ethical issues in interventional nephrology. I have been talking about ethical issues in interventional nephrology at this forum for now a few years, and I'm glad that you find some value in inviting me again. So once again, thank you. Uh, my disclosures here, I'm not an ethicist, but I do strive to practice ethically. So I think the bottom line here is we as clinicians, we often take risks. We often run into issues that are morally not aligned with your own values. We are often concerned about legal issues, and so I would like you to take home a message that practicing ethically what aligns with your values is, I think, the ultimate goal here. Uh, and in a nutshell, medical ethics is trying to do the right thing while achieving the best possible outcome for every patient. We cannot uh, provide treatment 100% cure to all our patients, but at least we should strive to do the best possible for every patient and put in our best foot forward. And the principles and theories in medical ethics apply to just about every problem or every situation that we face on a day-to-day basis in our clinical practice. Uh, I know some of the basic principles that I guess are covered by most of these ethics related talks. So, what I intend to do today in my allotted time is briefly talk about the principles of medical ethics and then use an example to highlight one of these principles that I encountered very recently in my practice. So, the four principles: autonomy, beneficence, non-malfeasance, and justice. These are the four tenets or the four pillars on which we base our practice on ethical values. And when we translate it to patient care, what do these values actually address? These values address the patient-physician relationship and interaction, and what we are striving to do is provide a fair assessment of the medical problem and evidence-based therapy that the patient can understand. We have a dialogue with the patients. We are honest and we respect their patients' values, the patient's family's values, and ultimately, it's a joint shared decision between the patient and the physician. So, when we talk of autonomy, what do we mean? Autonomy is right to control. It's informing the patient of the different options that the patient has, providing them a fair assessment of risks and benefits, and then allowing the patient, and if the patient is not able to take decisions, at least the next of kin or the power of attorney appointed by the patient or by the legal arrangements within the country. So in India, whatever is the legal arrangement, and generally in most places, if the patient is unable to take decisions, then the spouse has the first right to take decisions, then the siblings, then the kids, and then the siblings. So that's generally the followed norm. But if it is different, that legal framework has to be followed. And then once the patient and the family has been informed, whatever decision they take has to be respected. So respect the decision, even if it means it's against all your medical therapeutic principles, even if it means it's going to harm the patient to the extent of death. I think that it means allowing the patient to be autonomous and take that decision. And informed consent is one of the very routinely practiced autonomy, where if practiced properly, patients have the right to decide if they want to move forward with a procedure or not. And that's, I think, the first step anytime we decide to do a procedure related to the vascular access as well as related to the dialysis treatment itself. Beneficence and non-malfeasance, essentially, it means whatever benefits the patient is what we should strive for. We should not do any harm. So even though an intervention may be possible, if it's going to be more harmful than benefit, then that should be avoided. And there has to be a balance between good over harm. So just because a treatment is possible, just because we have the new technology, doesn't necessarily translate into performing that procedure if it's not going to make either an impact on the symptomatology or on the overall outcome for the patient. And when it comes to interventional nephrology or any procedural aspect of medicine, I generally ask these three questions. Is the procedure really indicated? And I think that's crucial. Then, is it safe to perform a procedure? I mean, patients may have an INR of 10. Is it right to do a procedure? Again, it depends on what the situation is. If the patient's potassium is 7, patient needs dialysis. Even if the INR is 10, placing a non-tunnel catheter is less risky. We can provide dialysis and save the patient. But an INR of 10 certainly is not safe to place a tunneled dialysis catheter, which is more involved and can always be placed once the patient is more stabilized. So asking that question, is it safe to perform a procedure, should be constantly at the back of your mind. And then lastly, when you're performing a procedure, you have to be cognizant of the fact about your training and your skills. Are you adequately trained to perform this procedure? So just because you can get a needle into a blood vessel, does that mean that you can perform arterioplasty? Can you perform selective renal angioplasty? Have you been trained for it? Yes, you can get the wire in, you can get the needle in, you can get the balloon in, but do you have the understanding of the pathophysiology? Do you have the understanding of the risks involved? And if there are complications, are you able to handle those complications effectively without causing more harm to the patients? Complications are bound to happen, and that's where the informed consent comes into the picture. But a complication because of your inadequate training, inadequate skill set is totally unacceptable. And justice, when we talk of justice, it boils down to complex healthcare issues and societal issues rather than an individual patient to physician relationship. It often entails the direction in which healthcare policies are drafted, and also depends on the social and economic structure of the society. So distribution of burden and benefit, allocation of resources. I mean, those are big things. Things that are possible in a developed country, are they always possible in an underdeveloped country? May not be. And then one has to decide, how do we allocate those resources for best possible outcomes? And how do we prevent misuse of those resources just because somebody has an access to it? So it's on a larger context we talk about justice, and examples from an interventional nephrology perspective is, yes, interventional nephrology has now grown in India and in Asia. People are recognizing it. There are government policies helping out with dialysis. Dialysis programs are more easily available than what I saw 25 years ago when I left the country. And patient awareness and the patient needs have gone up. Patients' affordability has gone up. So who should cover? One example of justice is, who should cover the cost of access care? Yes, dialysis is covered by various national health programs, various state health programs, or charitable programs, but do they cover the cost of access? If access care is not covered, then covering or subsidizing dialysis care is not really going to be of much benefit. If the patient cannot pay or is expected to pay out of pocket for angioplasty, or out of pocket for a new fistula, or an out-of-pocket expense to convert from non-tunnel to tunnel dialysis catheter, if that's not possible, uh, yes, it's going to create bigger challenges, even with adequate programs in place to provide dialysis. And so people who are involved with policymaking decisions should be made aware about incorporating access care into bundled universal dialysis funding. And that's just one example that I would like to highlight here. Now, having said this, I would move on to one topic today about autonomy and informed consent. This case actually I saw last week in the ICU, a 68-year-old gentleman who was admitted with the AML blast crisis, with pneumonia, severe hypoxic respiratory failure, and on a ventilator. He had undergone a bone marrow transplant about 5 years ago, and now obviously that has failed, and he's in a blast crisis. He has acute kidney injury, he's anuric, and he's getting very close to needing renal replacement therapy. Now, here at Cleveland Clinic, if there is no contraindication, and if in patients like him, where the anticipated need for renal replacement therapy, either intermittent or continuous renal replacement therapies beyond 7 days, we try to put in a tunnel catheter up front. We don't put in a non-tunnel and then change it out to a tunnel catheter. So the idea was to talk to the patient, provide them the information about dialysis, about the access issues, and then see how we could proceed. Since he was on a ventilator, obviously he was not in any position to communicate or give us the consent. His wife, who is the legal power of attorney, could only speak Spanish. His 3 kids, who are bilingual, they spoke fluent English and Spanish. So now the big question comes up is, what would be an appropriate way to obtain a consent for central venous catheter placement? And from my practice experience, what we came up and we have practiced is, patient or power of attorney has the right to control therapy. The informed consent is critical before embarking on any invasive therapy, especially in a very sick patient like the patient that we had. And it's ethically and legally binding. So we need to make sure that we respect the final decision that the patient or the family takes. And so here my approach was, we used an official interpreter. Wife couldn't speak English, kids could speak English, but it's always good to have a third-party official interpreter rather than ask the kids to be interpreter, because you don't know how the kids would translate information to the spouse. And so we used an official interpreter, explained the risks and benefits of all interventions about renal replacement therapy, catheter placement, including immediate complications like arrhythmia and death versus renal replacement therapy, and long-term outcomes in light of his bone marrow, in light of his AML and AML and blast crisis. So certainly it was an extended discussion that we had with the patient's wife. She took some time to decide as to what would be the best course. She had some discussions with her husband on the quality of life issues and what he would want to do in case he was incapacitated like he is in this situation. And so, having gathered all that information, we waited for the power of attorney, the wife, to take a decision, and she wanted a few hours to think about it, and we documented it, and we did not proceed immediately. After we reapproached this with the spouse, and few hours later, she came back with the decision to withhold renal replacement therapy, fully understanding the risks and benefit. Again, we used a third-party interpreter to allow us to communicate. Spouse was certain about her husband's wishes, and eventually the medical therapy alone was continued, and as expected, patient succumbed to his disease. So the take-home message here is, healthcare professionals have an obligation towards patients. We have to be truthful and trustworthy. We have to respect patients' autonomy. And that's exactly what we did. And I think with the Indian context, with so many languages, not every professional can speak or communicate. And I think we often, at least that's what I used to do when I was there, would take help from the family members, and one can never be sure what the family members intuitions or family members translation or their personal motives may be, and one is then blindsided into the decision process with the intent to be trustworthy, but may not necessarily be in the patient's best interest. So uh, I think this example really highlights the autonomy offered to the patient and the entire process of consenting. With this, I would end this presentation and really like to thank again Dr. Jasuja and the organizers of Cleveland Clinic. Wish you all the best and hope you enjoy this year's virtual avatar meeting. Thank you very much.